who does trauma and even non-trauma centers. Situation for these, but it's also something very appropriate for level 3 to manage these particular patients, particularly if they have isolated injuries from ground level falls. Our speakers today is Dr. Carrie Watson, who's the Trauma Medical Director, and Chelsea Sutton out at Piedmont Medical Center in Rock Hill. And we look forward to your presentation and look forward to the question and answer at the end. Take it away.
All right. Hi, everybody. I'm Carrie Watson. So I've been down here at Piedmont for about a year now, but we can kind of click over to the next slide for me. So just a kind of background on me and kind of where I came from and what brought me to the area, since I'm a little newer. So I am dual certified in general surgery and surgical critical care. I am a DO and did my training at Philadelphia College of my residency was actually in Ohio at a level 1, and then I did my critical care at Shands University of Florida Hospital in Gainesville at a level 1, and previously was working at a level 2, a very busy level 2 hospital down in Ocala, Florida, and then ultimately made my way up here. But that's a little bit about me. All right, next slide.
Good afternoon, everybody. I'm Chelsea Sutton. I'm the Trauma Program Manager here at Piedmont Medical Center. Thank you guys for having me today. I've been in this role since April of 2017, and prior to that, I was an emergency department staff nurse and clinical supervisor. I've worked at Piedmont for 15 years this summer. I celebrated my 15th year, so I've been here quite a while. And we are excited to be here today for you guys. Scott, you can go ahead to the next slide. So we have no disclosures today. I'll briefly go over what we're going to talk to you about today. So we all see hip fractures every day, but we just want to talk about how they impact the trauma system and then the overall healthcare system in general. Complications associated with hip fractures, and really the benefits of the multidisciplinary approach to the management of these patients is the bulk of what we're going to talk through today. And then we'll talk about some pre-hospital care and prevention strategies for our geriatric population as well.
So hip fractures, why do they matter? So Dr. Singh hit on it, I mean, perfectly. Hip fractures, especially isolated injuries, orthopedic injuries, I think impacts every single trauma system in different ways, because no matter what, somebody has to take care of these patients, and ultimately they are a high-risk population for having ongoing complications. They have oftentimes a lot of comorbidities. We're talking about most of the time elderly population. So 20% of our USA population now is 65 or older. I mean, it costs the medical system billions of dollars. And ultimately, falls remain the #1 cause of accidental injury. And having come from Florida, where a lot of my patient population was this exact person, I got up to South Carolina and guess what? Found the same thing. So ultimately, we know that mortality goes up a lot if these patients don't have surgery. So we're looking at up to 70% mortality within a year if they are not operated on, and 21% whenever they have surgery in an expedited fashion. So, I mean, it makes a huge difference on outcomes for these patients. Next slide. So again, we all know this, we all feel this. It's an aging population. You know, people are living longer and actually having more productive lives later in their years. So there's 36 million falls yearly in the US, 36 million. And 28% of adults over the age of 65 report a fall each year. I would say that kind of in the southern states where we have a lot of that population that comes down here because of our weather, warmth, things like that. The Carolinas get a lot of that same kind of snowbird population that comes down. So we take a lot of this population. So 37% of falls require medical attention, resulting in 8 million injuries. And so when we did a comparison to looking at the national average, we're right there with everybody. So it is impacting our system greatly. Of course, women are at higher risk. There tends to be more frequent falls, and then considering higher risk for osteoporosis. So really, this is the biggest impact. Is kind of the next impact that we can make is realizing that once someone sustains a hip fracture or one of these injuries, how does it really impact their life overall? Because it's not just while they're here. It's the goal is quality of life and getting them back on their feet. And so a hip fracture patient has 5 to 8-fold increased mortality in the first 3 months after their trauma. So that's because of functional limitations, self-care, deconditioning. We all know that being in bed for 24 hours, even if you're, an 18-year-old, it's amazing how quickly people get weak, and those core muscles, really limit people being able to get up, especially on a hip that's broken. So these patients suffer decreased strength and altered balance, increasing the risk of additional falls. So when we think about some of the higher risk after a hip fracture occurs, DVT and VTE is a big one. We're always constantly in the world of trauma talking about early chemoprophylaxis for DVTs and VTEs. And this population is huge because oftentimes if they're not getting out of bed or they're not having their surgeries and moving forward, they're laying in bed. And of course that puts them at higher risk. So previous studies have reported incidents of perioperative DVT due to hip fractures, including femoral neck fractures and IT fractures ranging from 11 to 34%. And then pressure ulcers are a huge one. Again, the longer someone's in bed and not moving around, if they don't have that strength and ability, if they're going to long-term acute care facilities and not being able to mobilize, pressure ulcers are a constant concern. And this risk can be between 8.8 up to 55% in the literature. Next slide. So, of course, this is kind of what we see. So when we have our patients that come in and you're having the conversation, realistically, once they have the fall, the longer they're down, the increased risk for everything. So the timing is kind of the real focus on what we're trying to achieve, especially and these are really the patients who were previously mobile or able to get around. You want to get them back up on their feet as quickly as possible. The longer that they're immobile, they become more deconditioned, which leads to pressure ulcers, VTE, infection, all of that. So of course, less mobility equals more morbidity. Next slide. So hip fractures and trauma centers. So I have been at a lot of different types of centers and structures, and ultimately the real question here is to trauma or not to trauma. And what we're really talking about is, do you really need to admit these patients to a trauma service? I'm sure some of you out there don't have that system in place, but at a level 3 center, as Dr. Singh mentioned, we see these patients a lot, and oftentimes we are kind of the cornerstone for managing those patients with isolated hip fractures and orthopedic fractures in order to get them in and out of the hospital faster. So when you're kind of looking at your system, these are some questions that I would pose to you to be thinking about whether or not is your system working well for your isolated hip fracture. So pros and cons based on your center size. Do you have a geriatric service available? So obviously, if you're at a center where you have a provider who's able to do specific geriatric medicine, that might be something that's very beneficial for early conversations regarding goals of care, explaining DNR and rescinded DNR, and if that's, the way that you're structuring things for those family conversations. If you already have a hospice patient coming in and you're talking about pain control, ultimately, some of the larger centers tend to have some of these service lines that we don't have available to us. And so we become all of those things kind of rolled into one at a level 3 center. So then also talking about internal medicine residency programs. One of the things that we've seen a lot more recently in larger conferences that we're all talking about, where do these isolated hip fractures need to fit in? Should they be going to medicine? Should they be going to ortho? Who should take them? And I think one of the biggest thing that we found in literature is that having some sort of a multidisciplinary approach where you have people looking at all of the comorbidities is very helpful. And so if you're lucky enough to have internal medicine residency programs, this could be an opportunity for them to learn about these geriatric patients, learn about geriatric medicine as well. But again, at a level 3 center, when we don't have that, we are also serving that role. Orthopedic surgery residency program. So this happens a lot of times at our larger institutions, our level 1s, where you have residents from all different backgrounds. And sometimes it's much better for the orthopedic residents to take on that role of having an isolated hip fracture be on their service as primary. They're learning all about how to clear them, get surgery done, and move forward. But ultimately, they have more feet on the ground. They are able to, get those. You have kind of a system in place with your residents to get them in and out of the hospital quicker. At a level 3, oftentimes we don't have those residency programs, which we do not. So we're serving that role. And then multidisciplinary approach. So really, that should be what everyone is trying to achieve. I think regardless of level of trauma center, is the more that you can have people involved looking at the patient and moving things along and streamlining your process, the better. And so that's what we put a lot of our energy here is, since we don't have all of the above, we don't have all of these residents, and we don't have a system in place for an orthopedic to kind of jumpstart all of this. We wanted to really grow the multidisciplinary approach where we can help facilitate getting these patients in, getting them stabilized, getting them cleared, and getting them repaired so they're on their way out of the hospital. And of course, what we're all trying to achieve when you're looking at, should I start admitting these patients to the trauma service, or should we be looking at a model that's more related to admission to a hospitalist service or the orthopedic service with a hospitalist consult, is what are going to be your targets, right? What are going to be the metrics that you're looking at? And we all know these. We're all looking at length of stay. We're looking at readmissions. If there are any coming back with any hospital-acquired issues, VTEs, pressure wounds, things of that. And of course, standardizing care. If there's one thing that trauma as a system is really familiar with, is that if you can come up with a really good algorithm or a really good way of treating every single patient with, these are going to be our goals, this is how we get through things, you have a lot less of that Swiss cheese model and a lot more of people understanding the process. And so one of our goals here into trauma or not to trauma is to take away some of that question of where do we start and where do these patients start the process. That way, everyone in the hospital knows, okay, this is where we go and this is the next step. So why did we start thinking about ultimately how we're going to treat these patients differently at a level 3 center? And ACS recommendation for trauma patients be admitted to a non-surgical service be less than 10%. So I know that not everyone treats these, patients if you have a streamlined process, but the system that we're going to be talking about and why we did what we did can be applied to other QI and PI within your hospital. But part of our reasoning for really wanting to hone in on this issue is that there was so much variation in where patients were actually being admitted that ultimately it wasn't a streamlined process and patients were receiving different care. And so we wanted to kind of encompass our isolated hip fractures into our trauma admission. And of course, our goal is to get that less than 10%. And this all comes from the idea of co-management. If you've done any lit review or research or been to any conferences in the last 10 years or so, this has been kind of a hot topic of what is really the best way. And honestly, the answer is the best way is what works for your system. I don't think there is a best way to manage an isolated hip to say they should all go to hospitalist with an ortho consult or they should all go to trauma. That's not what we're here to say. But I do think that every single group that you look at has found that an idea of co-management and multidisciplinary approach where you're involving someone managing some of the comorbidities, that some of the medical comorbidities, on top of having a streamlined process for getting them to the OR, and then also having that multidisciplinary approach for your case management to talk about directed goals of care and living will, as well as your physical therapy team and your rehabilitation team. Pretty much any literature that you're looking out, it indicates that that's how you're going to get your best outcomes, is that co-management idea. And then ultimately, one of the articles that we were looking at was by coming up with some of these processes, you're able to get people out of the hospital ultimately faster. Okay, next slide. All right, Chelsea.
All right, so that is why hip fractures matter as a whole to the healthcare system. So why does Piedmont Medical Center care so much about standardizing the care of hip fracture patients? If anybody is on from a trauma center within the region and has had the pleasure of going through an ACS verification visit, you very likely got a list of weaknesses that are basically just things that you work on. And it's identifying opportunities for improvement, which is kind of what we do in trauma 24/7. If you work in trauma or work in quality in any way in your hospital, you don't see these as a bad thing. You're always looking for something to make better. So this was one of our weaknesses when we had our verification visit in April 2019. So our current goal for time to hip fracture of within 48 hours of admission or less was too long. They basically said you need to cut that in half. Studies are showing all the different things that we just reviewed with Dr. Watson. Studies are showing that patients are doing better the faster that you get them in and out of surgery. So when the ACS does point out something like that, you better address it. It's a good idea to really look at it and come up with a process in place so that you can give them that action plan and show them that you've made some improvements. So the recommendation was obviously to cut this in half. And like Dr. Watson was saying, standardizing care is really what trauma does as a system, kind of every day, all day. So coming up with a practice management guideline was what we set out to do. When we were able to do a retrospective audit on our hip fractures that were in the previous years before our visit, we did find that the longer it took to get them to surgery, they had increased length of stay. They had more readmissions. We had several VTE events that happened after the fact. So really this was a big project that we were able to take on in late 2019. So go to the next slide, please. So I mentioned working in trauma or working in QI or PI. If you are in one of those positions at your facility, utilizing a PDSA model is something that we have found very useful. And this really just streamlines the process of what is your performance improvement project. It's a great tool to use to break it down. And it's a great way to put it on paper and display what you've been able to do for your problem. Jumping right to the outcome doesn't really help prove how you got there. Like showing your work in half class is basically what I'd equate it to. You need to prove what steps you were able to take to get to the end result. The work is never going to be done. And as you can see, when you make your plan, which is what we'll go through in just a second, you carry out your steps, you're almost always going to find, oh, that probably didn't work. We need to do this a different way. And it's just an ongoing cycle of how you're integrating that performance improvement model into the particular topic that you've done. This is also great for showing this work to regulatory visits and to surveyors. It's a great tool to use to show what work you have done, and they are very impressed by it. Next slide, please. So we got our team together and we said, this is what we need to do. We need to streamline our process to get these hips in and out of the OR as often as possible in less than 24 hours. So we really got to work on this in late Q2, early Q3 of 2019 after our verification visit. We mainly focused on the multidisciplinary approach. So we were able to get representatives from hospitalist medicine, orthopedics, our OR leadership, case management, pharmacy, rehab services, trauma, really just to come up with the great process to get these patients in and out. Our key components there were the early injury confirmation and ortho consult. So I'm sure every ER in the country is definitely having these struggles now, but ED throughput is always an issue. And the earlier that you can address what the problem is and get the right players on board, the better your throughput is going to be. So we had some issues that we noticed that sometimes these hip fractures weren't being confirmed for hours after they've been in the ED. So really working with our ED team to identify the patients that are at high risk, what anatomical things to look for, just asking the right questions, making sure that we're alerting these patients at their risk for injury as soon as they hit the door so that we can confirm within an hour ideally and get the right consults on board. Pain management was a big project that we worked on from the trauma service. We utilize a multimodal approach and we were able to get different order sets built into our EMR that also included our non-pharmacologic approaches as well. We also discussed the fascia iliaca blocks as well. We were able to pull some literature and see the success that we had with those. Different centers are doing that process in different ways. We talked to some centers where emergency medicine was placing these blocks. Some centers, anesthesia was doing it. It's done differently everywhere. And in full transparency, we weren't really able to come up with a great process for it here. But I would definitely recommend it at your center if you don't have a process in place or have a pain service that's able to help with that. For early surgical planning, this was something that we made sure we included as far as early notification of OR leadership so that these cases could get prioritized. So in as real time as possible, we made sure that we notified the OR charge, whoever was running the board that day, that we had a hip that we needed to go so that they knew it was coming and we could get it on the books. And then early post-op rehab, when we wrote our first draft of our protocol, we really wanted to make sure that they were seeing PT and OT post-op day 1. If not before. If they were able to get to the OR early morning, they would hopefully see PT, OT that afternoon. And we huddled together just like these little penguins did, and we really got started. So Q3 2019 is where we really saw most of our results. You can go to the next slide. So here I just kind of like to show you a little before and after. Like we said, ACS really did put this on our radar. This wasn't something that we were really tracking prior to. And so now that we understood that it was an issue, that was, a bad thing because we weren't really meeting our mark most of the time. But like I said, there's always room for improvement, and now we know about it. So we really moved forward. And as you can see, we did see some improvement in especially Q1 2020, where we were getting over half of our hip fractures to the OR within 24 hours. And then our average time to OR really started to come down as well. As always, there were going to be barriers to that. So it's not an expectation that this happens 100% of the time, but really standardizing that process to streamline getting everyone on board and aware of that this is the goal was a big part of our work. We did end up having some delayed cases noted in Q3 of 2019. One thing that we noted that's a good takeaway is we needed additional imaging to confirm the fractures. We had quite a few cases that had occult fractures that weren't showing up on plain films. And we were debating CT versus MRI, what has the highest sensitivity, and then comparing that with your MRI availability. Again, we're a level 3 trauma center, so we don't typically have MRI availability 24/7. So those can add in some delays in getting patients' injuries confirmed. So we noted that as a struggle and took that into consideration. But we were really proud, really proud of the hard work that we had done. Next slide. This next slide basically shows the same data, just shows it in a graph format. So very objective. We put it on paper and kind of showed that this was possible. When we first gave the 24-hour time frame to everyone involved, it did seem kind of daunting that you can get all of that stuff together and get the patient to the OR to have their hip repaired in that short amount of time. But we were able to prove that you could do it. And so we were really proud of those results. And then next slide. So this is probably how every single one of you felt when the pandemic hit and when everyone was sent home packing and everyone got really familiar with these virtual experiences. And not only did all of these frustrations and all of these facial expressions probably hit every single one of you, you'll see on our next slide that our metrics really started to go way down. And understandable, right? Our generation has never seen a pandemic like we've just been through, and we had to reshift our priorities and really figure out what to do, how to take care of people during all of this. So expectedly, the average time to OR just went right back up. We weren't meeting our target, and we really were having difficulty standardizing how to manage these patients with an ongoing respiratory virus going around. So as you can see, COVID was the major culprit in us regressing in this project we had. Staffing was an issue. I'm sure everyone on the call today can attest to that. Really just getting enough humans to take care of the other humans became a problem. And that obviously is going to cause delays in care. Intubation strategies, that was a constant struggle as well early in COVID. We were talking through our anesthesia team and really just coming up with ways on scheduling cases, how they were going to do their anesthesia protocols, and all of those things really just became a hassle. We were able to make a little bit of progress towards the end of 2021, but if you'll go to the next slide. Oh, that's right. Sorry. Basically the same data, just in graph format as the previous slide. And yes, that's exactly how we felt, because we had done so well, but then the world stopped. So next slide. So this is not news to anyone, right? COVID had the same impact on just about every hospital system out there. Whenever you're starting a new process and educating everyone on how it's supposed to work, it truly feels nowadays, especially nowadays, that you're having to do it over and over and over again, because you're constantly seeing new faces in your four walls. So we're constantly retraining, re-educating, and making sure that we're telling new people what our priorities are. And that just became a big hassle. Constant policy changes. Everyone's been there, right, since COVID, when testing algorithms and exposure algorithms, what PPE you need to have on and for how long, all kinds of stuff, just constantly changing. And whenever that does happen, sometimes it obviously can really halt your progress. We did have some leadership changes. So our hospital got a new CNO and COO within the first 18 months of the pandemic. So anytime that happens, I know we've all experienced that, just different priorities, bringing everyone up to speed. And it just caused some delays in getting this project really off the ground. We also did have our triennial Joint Commission survey this past December. And everyone who's ever been part of a quality department before that knows that when you're in your survey year, a lot of the times that's all you're thinking about. That's what you're focusing on, and you're making sure that you're set for that. So not that it's a bad thing. Our regulatory agencies are there for a reason, and they keep us in line. But that's another thing that does halt progress sometimes when that's your main focus. So next slide. So we were really proud of all of our hard work, and we knew that we could do it because we'd done it before. So this was not something that we were going to back down from. So when Dr. Watson got here in September of 2021 as our trauma medical director, this was one of the main projects that we really decided to hone in on and focus on, and just get everybody back up to speed, hit that reset button, and let's go. So we looked at our original PMG again. Our key components really didn't change. The main thing that we wanted to focus on with all of the OR availability and the COVID restrictions and everything we had just been through was that early surgical planning, is making this a priority again. And then we did add one new component. Dr. Watson touched on it at the beginning, and she'll go into a little bit more detail too, is the admission to the trauma service. We really wanted to highlight the importance of that. And I'm going to let her take the reins and kind of show us the impact that made on this project.
All right, next slide. Okay, so ultimately, when I came to Piedmont and started last September, my entire goal was to meet with each liaison from each one of our specialty service lines and have some sort of a goal that we were going to really target. And so in doing that, I found with everything that Chelsea just went through, that one of the big targets they were trying to achieve was this increase or decrease time to OR for their hip fractures. And so when I was going back through that data, so she talked about that PDSA model. Well, part of that PDSA model is you have to do the S part. You have to study your results. You have to go back and look at the things that you started to do and what worked and what didn't. And immediately when we sat down and kind of ran through everything, I started to realize, well, one of the most inconsistent findings is the patients are not always being admitted to the same service line, and the hospitalist service changes on a weekly basis. So sometimes a patient would be coming in on a Monday and then being transferred to a different hospitalist the next day. And who controls that continuity of care, who's doing sign-outs. And so immediately I realized that when we're going back through the study portion of the PDSA model, one of the first kind of variables that we could easily fix is we are a level 3 trauma center. We see a lot of hip fractures. We don't have residents. We don't have a really streamlined process for this. Let's make it where all of these patients are coming onto our service line so that now we can be in control of who the timing to things and getting things jump started. So number one, that was kind of the first change, was trauma admitting these to the service line. I would suggest if those of you out there are struggling with any of these times, go back to the very beginning and make sure that you have just those basic, where's the person being admitted to and how are you ordering your consults, because it does make a big difference. So ultimately the next process I was looking at was when you have a lot of ongoing handoffs and switchover, which I get sometimes is tough to control. But one of the things that I realized that we were doing is every single day, different people were kind of rounding on the trauma service. And sometimes that would be a general surgeon, and sometimes that would be someone who was, more of the trauma surgeon. And so I felt that it was really important to me, as I had more APPs coming on and the trauma service line, was I restructured the way that we were doing our call to more of a rotation, 1 week on, 1 week off type model, with the traumatologist covering the Monday through Sunday, and the general surgeons kind of doing an every other night structure. And what that really did was every single day during 1 week, it was one trauma surgeon who was rounding, which really limited, again, the number of hands that things were kind of being passed between. Next was it's very obvious to all of us that without a functional emergency department, it's really hard to be a functional trauma service. So I really wanted to spend some energy first in engaging my ED leadership before I even kind of jumped off the ground. And so we are lucky enough to have ED leadership that values doing PI and QI. And so we actually gave a few lectures and conversations early on about each one of the targets we had for our service lines. And so again, back to orthopedics, is really going to be hip fractures. So we went to these lectures, we went to their meetings, and I said, hey, this is really going to be your target. Those high risk people, the elderly that are falling, you have that externally rotated hip, identifying them early and encouraging them to recognize that we want to get them to the OR within 24 hours from the time they arrive. So calling us quickly, we told them, hey, these patients are coming to us. You no longer have to worry about who to call, waiting for a call back, whether or not someone's going to call orthopedics. We're going to help you with this. We're taking this on. I also feel that it's very important to recognize the role that your hospitalist service or internist service in your hospital can play in this, because again, back to that multidisciplinary approach. So then I also met with my hospitalist liaison and I said, one of the changes I'm going to be making is your service line is no longer going to be admitting these patients primarily. However, your service is very important to me. So let's make sure that we're working together to make sure that we have cohesion for these patients. And ultimately, we came up with an agreement that any hip fracture that was coming in over the age of 55 would also get an HM consult for medical management. I bring this up because, we are a community hospital. And I think that sometimes when you're sitting back trying to restructure things, you also want to make sure that you are not making major changes and that are going to be impacting everyone without including them in that discussion, especially in a system that really relies on hospitalist medicine for a lot of their admissions. And that's how Piedmont has been up until this point. So we had a fantastic conversation. I was able to talk to them at their meeting as well about why we're making this change and some of the things that they can assist us with. And ultimately, the other part of this was we were able to also come up with a transfer agreement that in these patients, once they were initially stabilized, got through surgery, and the trauma side of things were managed, it also gave us a really good way of building the conversation about how are we going to transfer these patients to the medicine service line if the trauma component is completed. And this is important because maybe your team is sitting back and saying, there is no way that we can keep every single one of these hip on our service. There's one surgeon, rounding on 30, 40 people. I think this is going to overwhelm our trauma team. However, you're looking. So one of the things that we really focused on was that initial stabilization, getting them through surgery, making sure they're not having acute blood loss anemia, getting physical therapy involved. But if they're still in the hospital because they have COVID or pneumonia, or maybe it's hypertension, or ultimately someone who just has multiple medical comorbidities and they're waiting for a rehab bed, we were able to come up with an agreement to transfer those patients over to the medical service once they were stabilized. Next slide. So ultimately, this is just kind of showing the percent hip fracture admitted to trauma service. And this was a lot of moving pieces because I had to make sure, number one, the orthopedic team all knew, hey, when you guys get a phone call, it was in their kind of normal response to say, okay, admit to medicine and I'll see him tomorrow. You guys have probably kind of all heard that before, right? So I made it very clear to the ED group, the orthopedic group, as well as the HM group that whenever you get these patients, as we start to kind of unfold this change, it's going to be kind of a question where people are going to be, all right, admit to medicine versus not. And we all have to work together to remember that these need to go to the trauma team. And we got it started at the end of Q4 of 2021, and you can see how quickly we've had no admissions to non-trauma service since this got started earlier this year. So again, this was just kind of the first piece, was getting them onto the trauma service. Next slide. Okay, so next was really now focusing on, okay, now we know that we're getting them, we're streamlining the process. Okay, so step one, they're all going to come to us and now we can be in control. So now 24 hours, we really mean it this time. So what has to happen with this? Buy-in. I mean, that's the truth, right? Anytime that you have a new initiative, you have to have some sort of a buy-in. So I focused first with orthopedics, and I brought my liaison in and I said, okay, this is going to be our target. This is something that, you know, everyone is really focusing on in the trauma world, and we know that we get better outcomes. What do you need from me to make this happen? And of course, Chelsea and I did all of our planning, and a lot of this, you know, come to those meetings with questions. And I will say to you, not any of my meetings with liaisons are longer than maybe 15 minutes, 20 minutes max. But I brought to him, I said, this is going to be our goal. They're going to be coming to our service line. We're going to be the ones contacting you guys and getting this going. How can I help? And really, it was a lot of, we need the OR time and jump starting how we can get these patients on the board and understanding that they're more of that urgent case. And I had to talk with them about, hey, when you have several cases that you're booking that are elective cases, coming up with ways that you can work together within your group to share these patients, offload, things of that nature. And so after talking with them and they realized, hey, I've got your back, we're going to talk to the OR about prioritizing these patients. And then they really were gung-ho for it. So the next was OR leadership. So this, I met with our OR director, our charge nurses, as well as anesthesia. And so ultimately, we still don't have a dedicated orthopedic trauma room, but one of the things that we really worked on is utilizing kind of that flip room that ortho has, or an extra, kind of keeping an extra room available for more of those urgent cases. And so we haven't created a dedicated ortho room, but we've really pushed in the direction of having more of an urgent room that's separate from like the trauma room available for getting those cases done. And then using that as a flip room if nothing is available. So making sure that we have kind of buy-in for that. Okay, next slide. Okay, so then once I knew that, okay, my orthopedics team is on board and my OR staffing and my charge nurse, and they're like, okay, we get this 24 hours. Then I had to go into the clearance games. And I mean, it truly felt like this. So I'm a big believer, again, in making sure that we touch base with each one of these service lines to make sure we're all on the same page, because if I can't get everyone to kind of work together on this, then it's going to be futile. So next, I kind of went with cardiology. When we went back through our PDSA and looked at what were some of the limitations, oftentimes it was clearance for surgery. And unfortunately, there was all too many circumstances where someone knew that hip wanted to get done, orthopedics booked it, and then they made it to surgery, or someone was evaluating and they were like, oh no, we don't have an echo and we don't have a cardiology sign off. Oh, send them back upstairs. And, you know, it was just not an organized way of doing things, and there was no really clear path. So I started with my cardiologist, who was our our liaison for medicine, kind of directed me in the way of who to talk to. And so ultimately I went to head of cardiology, and we sat down and I said, hey, this is an issue that we're having, and we're trying to get these patients to the OR quicker. And oftentimes we really rely on your input and your clearance to get them here. So let's sit down and come with a very clear algorithm. Let's come up with a card that we can all have, that we know who are the people that we're going to recommend getting echo and who we're going to recommend a formal cardiology consult to get these patients through. So we sat down, he gave his input, we came up with, and we used data that's out there going through East guidelines about clearance. We put together a little card, and I said, okay, now that I have your recommendations, before I jumpstart anything, I got to go to my anesthesia crew. So then I met with my anesthesia team. And I said, I've already met with cardiology. I already have my buy-in from orthopedics. You know, I did all of that legwork first, because oftentimes kind of that anesthesia is that hard stop. So met with them, and I said, this is what we came up with. This is our list. This is who we're going to plan to order what imaging based on all of the agreement from the cardiology department. What do you think? He then took it back to their group. And all of this happened within a matter of a month, mind you, because, you know, we got the ball kind of rolling quickly on this. He took it back to their monthly meeting. They had a conversation, had a couple of changes they wanted to make. I then had a quick conversation between cardiology, anesthesia, and myself. We all agreed on the changes and said, okay, this is now going to be our clearance and our indications. And then ultimately, the other moving piece in this is our echo techs. So I engaged them very quickly, and I said, hey guys, you guys are incredibly important for getting these cases done. We're going to start ordering these echoes whenever it's indicated and putting in there for pre-op clearance for hip fracture. And when you see that, know that our goal is 24 hours to the OR. So it actually became kind of fun for them. And I've now met the echo techs, and we have this great working relationship, and they text us now and give us all the results as they're doing it. And they understand the importance, and they get to hear about the results. And so now they're engaged in the process as well. Next slide. Okay, so this is ultimately what we came up with. Again, some of you may already have this out there, but I did feel like it was important to show you what ultimately we came up with that works well for our trauma system, for our trauma hospital. And we actually made little cards and laminated them. And so all of my trauma team, my APPs, and the ED, if they wanted them, have access to this card. And they can pull this out whenever they see a patient, just as a reminder. So that way, if you can't memorize everything, but ultimately, this is exactly how we approach the patient. As soon as someone comes in, fracture is identified, they get admitted to the trauma service, the orthopedic surgeon's contacted, the OR is made aware, and then we look at this and we say, okay, do they need an echo or not? If an echo is indicated, we order it stat with the finding in there. This is for pre-op for a hip. And then if a cardiology consult is placed, we contact that provider directly and say, this is our goal. So again, this works really well for us in this kind of setting. Next slide. All right, so after all of that conversation and talking, we said, all right, it's go time. So here we go. All right, so right after, what's that?
Sorry, go ahead.
Okay, so yeah, no, this is you. Go for it.
I thought so. All right, so really making this a priority and sitting down and planning out, like Dr. Watson said, these conversations with each of these key players in this multidisciplinary team truly showed to be a huge communication satisfier. And as you can see, we were really able to make some huge strides here and getting our patients to the OR quickly. Our average times went way down. And we actually were able to get all hip fractures, I think in the month of April this year, to the OR within 24 hours, which was amazing. The other key point that I will say is that it was super important for us to keep showing this data to every player involved. And just to say, hey, this really does work. This project is worth it, and we're able to do it. And congratulations on a job well done to all of you this most recent month. So this is a line item now in our monthly system meetings. We're able to go through this with all of our multidisciplinary team in the room and just go over what our rates were the previous month. And this is what worked. And this is another problem that we may need to address moving forward if we start to see a trend. But constantly, reminding everybody of the goal and hitting that reset button has shown to work really well for this program. Next slide.
So realistically, I think one of the driving forces that helps everyone to kind of keep moving forward with something, just as Chelsea mentioned, is to know why we're doing this and what the results are. So just as she mentioned, we are presenting that information, but also we are constantly looking at, as you are as well, looking at your hospital associated events, as well as morbidities that can happen after injuries. And since we have started this in 2022, we have had no readmissions for our hip fractures. We've had no VTE, including DVT. We've had zero. Because the trauma service line, we have a huge initiative for getting DVT prophylaxis started immediately. That's a whole nother conversation, but we've had zero VTEs. We have a PT is getting them up on hospital day, or sorry, post-op day 1 or sooner. And so our case management team is really jump-starting that rehab planning process. And so even though we're not seeing huge changes in our length of stay, most of the time that's actually more related to authorizations, as well as the impact of COVID and people not being able to get beds, things like that. But it's not being impacted by the fact that we haven't been able to get an assessment, which was one of the issues that we were finding before, whereas we didn't even have assessments done quickly because they weren't always getting out of bed immediately. So those were some of the things that we found. Now we're kind of doing further deep dives into these patients to kind of look at where are some other areas for improvement. So what we are starting to look at is now, because it doesn't ever stop, looking into the future, post-op transfusion requirements correlating directly with IM nail repair. So we were looking at some of our patients requiring blood transfusion, things of that nature, and keeping a watch. Blood transfusion is a big topic too with our blood shortage. And so anyways, it's one topic that we're looking at, and we found that it hasn't been impacted by our more kind of vigorous VTE dosing. And so we're just keeping a watch. And then also moving forward, we're developing kind of more plans with our anesthesia group about really those high risk patients that are still complicating our clearance process. So when you look at the percentage that are not making it to the OR within 24 hours, almost 100% of that grouping is because they need some sort of further testing, like a stress test, or there's been some sort of anesthesia evaluation where they have significant pulmonary hypertension or valvular stenosis, and they want a CT surgery eval for should this person get a valve first. So again, the clearance games, it's like the second round in the movies where she gets drawn back into it. I'm still fighting the clearance games fights. But we're still working on trying to figure out how to best streamline that process so that we're providing excellent patient care and getting them to the OR safely, and making sure that the next round of events is going to be getting the ICU team involved in kind of more of those high risk patients. So that way, whenever they're going to the OR, we have that kind of set up. And then of course, early palliative involvement. We don't always have someone in-house or available for on-call palliative consults, but we are lucky enough to have a team that does assist. So that's kind of our next push too, is to get them involved in those discussions to make sure that when we're talking about recension of DNR, or sometimes we're doing hip fractures on patients who are already on hospice and we're doing it for pain control, we're trying to streamline the process of getting them fixed quickly and back to hospice more quickly. So that's the future for us. Next slide. We also absolutely want to acknowledge the EMS role. I mean, goodness, I'm sure that y'all know your EMS crew makes or breaks a lot of times that kind of initial getting people here and early identification of injury. And we're very lucky. We have a very involved EMS crew down here, and we often participate in conversations with them and lectures and talking about what our goals are. So just also encouraging them, and we're involved in a monthly EMS PI meeting where we go through some of the hot topics for us. So some of their target goals, what they're trying to achieve. And it's just, we've been doing education on assessing those distal pulses, and anytime they see a deformed lower extremity, those foreshortened externally rotated extremities. So getting them used to that. Oh, I need to make sure I check a pulse. Adequate pain management in these patients. They have a community paramedic program that they're really building and working on to help teach these newbies coming out, kind of what to look for and what to do. And then of course, kind of doing more outreach for those at-home risk assessments. And Chelsea can talk a little bit about that.
Yeah, so I know some agencies in the region do have community paramedic programs in place, and I think this is a great avenue to do, on the spot outreach, and then after the fact, after discharge outreach on fall risks and things that these patients can do at their homes to decrease their risk of falling and breaking their hip or, having any other injury as well. Scott, if you can go ahead to the next slide too. This is where I think injury prevention and fall prevention in general is so important in, nationwide, but especially in the South and in our region for all of the risks and everything that we talked about at the beginning of this lecture. So if you are involved in your injury prevention at your facility or in your community at all, if you're not, I would highly recommend getting involved. I know our MTAC region has a wonderful subcommittee that is part of our MTAC committee as well. And there are some great professionals in this region that can get you connected with different community partners that can give you a ton of resources. There's all kinds of stuff to do to get out there into the community. One thing that we utilize here really in just simple patient giveaways is the STEADY program that comes out of the CDC. We're able to utilize our PT therapists to perform a quick tug assessment on patients while they're doing their evaluations and get that documented. And then we've got, at-home materials to give patients to do their own home risk assessment on precautions they need to take at home to make sure that they don't fall, that a family member doesn't fall, that they don't fall again. There are matter of balance programs out there that are great programs for facilities to help with just really increasing that core strength and balance and things that are going to decrease these geriatric falls. Tai Chi is a great example. Getting local courses at assisted living facilities, different rec centers, things like that. Getting those organized in your community. And then high risk patients, I think it's just important to educate them. Working with cardiologists and primary care doctors. It's so funny to see every patient over 90 that's taking both Eliquis and Plavix, and you just want to pull your hair out and say why. But making sure that those patients are getting the right education on what to do should they fall. They may not be getting that from their prescribing physicians, so I'm really making sure that they have access to that. This is a flyer that we were able to put together as Piedmont for Fall Prevention Awareness Month, which is every September, if you didn't know. And just papering your walls of your hospital, putting it on your website, your social media pages, and just really getting it out there for the community to see, just tips and tricks that people can do at home to decrease their risk. All right, next slide. So this is what we feel like. We are very proud of the work that we've done. And as you all know, and as we have said here, it's never ending. The work is always there, but we're really proud of the progress that we've been able to make. And I think Dr. Watson and I will take any questions if there are any.
Happy to. Thank you guys very much for allowing us to have this talk.
Dr. Watson, Chelsea, thank you for that presentation. I don't know if there are questions, right, but I have a few questions myself. So one of the things that we've learned, and it's obviously a challenge, is that particularly for these focus groups, your metrics tend to do a lot better with a focused team as well. And historically, we've had some very focused multidisciplinary teams that includes occupational therapy, physical therapy, specific to a patient group like this. So with the challenges now, with a combination of one, capacity, I know everyone's overbooked in their hospitals right now, as well as staffing shortages. How is that playing into trying to, again, keep this an efficient modality? So do you have a specific therapists that work with these specific patients, and do you have a specific unit where these patients would reside?
So great question. Primarily, the majority of our patients end up on our med surg area, which is mostly located in our women's tower on the third floor is mostly where these patients end up. Occasionally, if they have more multiple comorbidities or PCU, which tends to be the third floor on the other main kind of part of the hospital. But the main thing that we have going on is exactly that, a lot of engagement at our multidisciplinary trauma committee meeting. We bring in our other representatives, and that would include our rehabilitation services. And we have their direct phone numbers. They're plastered all over everywhere. And our APPs keep their phone numbers in the phone. So what we do is as soon as someone has had surgery, we immediately put an order into PT/OT for assessment and say in there post-op hip, or, for reassessment for rehab planning. And they know that whenever that goes in there, it's to get them up moving after injuries. Unfortunately, we are very limited, again, capacity on staffing. So we don't always have the same therapists that are here. And oftentimes the weekends really hurt us because our staffing even goes to half of that. And so oftentimes they're kind of picking one day or the other. So one of the things that I kind of do whenever I'm talking to them is I have PT stars, and those are my people who are the ones who really need to get that initial assessment to get up out of bed to know which direction are we going. But as of right now, how we're doing that is just by putting the order in and putting in there why we're needing them to see it, and they know that's a target.
Dr. May has a question.
Hey, thanks so much. Addison May here, one of the trauma critical care faculty here at CMC. Great presentation. Great job on moving the needle so effectively for this population. Maybe a little bit in follow-up to Ron's question, but specifically regarding, quote, cardiac clearance. It's a personal pet peeve. For this population, we're actually probably not, you're not just trying to clear them, yes, no surgery. It's really risk. How do you minimize the risk? Because they need the operation regardless. And so whether or not, I guess in my experience, the skilled cardiologists who know the area and skilled anesthesiologists who know the area much more rapidly come up with effective recommendations that actually have interventions to minimize risk and then limit sort of diagnostic procedures and delays that aren't actually going to do anything for the patient's risk. So wonder if you have any thoughts on that, and if you have any perception on those patients that get delayed because, hey, we think they could be cardiac risk. What percentage of those actually have something done that minimizes their risk?
I love this so much because I'm going to invite you down to participate in my clearance games. I 100% agree. The majority of patients without evidence of a new murmur, new arrhythmia, no evidence of a STEMI on their initial echo or on their initial EKG, without signs of ACS or decompensated heart failure, what are we really achieving, right? So strangely enough, that was actually why I had to do this initiative for the echoes and clearance, because unfortunately it was the getting them to the OR and the wanting additional testing that I was coming into contact, as opposed to my cardiology and anesthesia team saying, we don't need all this. I was the one saying, we don't need all this. So realistically, the reason we kind of instituted that entire checklist was to streamline the process, because the majority of patients that are still coming through may or may not end up needing anything to be intervened upon. But ultimately, our anesthesia department is very, if you cannot determine the METs, you have to get an echo. So even, I'll just put it, every system has its own challenges, and this was the best way for us to streamline the process. And we've been able to get people to the OR faster by doing it this way. Our next step in this is actually to be looking at what are the actual outcomes issues that we're finding in complications, because when we're looking at the patients so far who have had like a death after, I think we've had 2 hip deaths. One of them was a cemented hip that ended up having a emboli, and the other one was a severe, basically a cardiac cripple with an EF of 10 to 15% who needed to have the surgery done, et cetera, and ultimately was in the ICU for some time and multi-organ system failure. And but part of the issue there was they didn't make it to the OR for 4 days because I could not get any type of clearance. And as we just talked about, they're still going to need the surgery. I would actually love any feedback or any information that you guys have about how you streamline those processes, because as of right now, my next goal, and including the ICU, is when we have someone with that moderate to severe pulmonary hypertension, oftentimes I'm getting some feedback of, we should really have them see a specialist. And I'm like, this is, we're not going to be able to do that in trauma patients. They need to have the surgery done. And so I'm now working with my ICU to just, if we have critical or severe aortic stenosis, and they need to have something done, making sure that we have adequate IV access, art line monitoring in the OR, having the pre-op conference where the anesthesia has a chance to actually see the patient the day before surgery. So that is actually another step that we're working on. But yes, if you have thoughts on that, that has been a challenge.
Love the concept of pre-op conference with anesthesia. Not sure that we've been able to, everybody's so busy and we're short-staffed that we're consistently able to do that.
So what we're doing with that, and actually just last month, because again, back to that S part, what we started realizing is those high-risk patients that do have any type of critical stenosis or a moderate or severe pulmonary hypertension, I actually told my anesthesia liaison, we're getting stopped still where everyone's kind of checking the boxes and we're doing this and we're planning ICU admission or we're planning, but then sometimes what happens is the patient gets to pre-op and then 2 hours before, that's when anesthesia sees them. And then all of a sudden they decide they want something else. And I said, we have to stop doing this. It is ineffective for what we're trying to achieve here. And so now what we do is we actually have a direct phone number, which is it's our 6200 line. And anyone who gets an echo or has a cardiology consult and is in that higher risk category because of those findings, they get a call that they're now in that process. So I'm asking them to go see the patient before the 2 hours before surgery. So we'll see how that goes. So maybe more to come. I can update y'all on how we're doing that.
All right, well, listen, I want to thank everyone, in particular Dr. Watson and everyone for their questions. I do, and Chelsea, we're kind of running over a little bit here. What a great topic. Let's see if we can come back to this topic in the near future.
Great.
Again, thank you everyone for participating and have a great day.
Thank you.
Thank you guys for having us.